I was thinking about how historic today is this transatlantic collaboration, and I was reminded of a Marx Brothers movie. Do you know the Marx Brothers? They were comedians, and there was, I forget which movie it was. I forget which movie it was, but there was this scene where Chico and Harpo pretended to be these very famous aviators, pilots, and they made the first successful transcontinental flight from Europe to New York. So there was a big celebration and a big ceremony honoring them, and they were asked, how did you do it? This is a historic feat. And Chico, Harpo never spoke, so Chico did the speaking, and he said, well, it was very difficult. He said, we built this airplane with all the most sophisticated engineering that we had, and we made it halfway across the Atlantic Ocean, and we ran out of gas, so we had to go back. So we then went back to the drawing board, and we created a better airplane with more fuel, and this time we got 2/3 of the way across the Atlantic Ocean. We ran out of gas, so we had to go back. But here we are today, third effort, and we made it, so it's historic. So I'll just share with you some of our efforts at the local level at Mount Sinai for patient navigation, and try to also, either in my talk or perhaps during the discussion, talk about the citywide efforts in patient navigation. Around 2001 or so, when the Commissioner of Health in New York City, Thomas Frieden, and Mayor Bloomberg decided that we have to do better for screening for colorectal cancer, there were several barriers that we at Mount Sinai felt we should try to address. Of course, we've heard a lot about this today, physician barriers, so failure for the doctor to recommend cancer screening, and difficulty arranging colonoscopy. So our solution was to develop an open access endoscopy setup. What this means is that patients could go directly from their primary care doctor, their internist, or the family doctor, directly for the colonoscopy. Prior to this, they would have to have a visit with the gastroenterologist ahead of time to explain the procedure and go over the prep. Our thinking was that that extra step was an inconvenience to patients. It delayed the process. So let's just get rid of the interim or the interval GI doctor office visit. So we call that open access. There were also problems at that time with scheduling and insurance. So again, we developed systems to allow our patients to get in directly for open access endoscopy. And then the biggest problem that we thought we would have is patient barriers. So fear, distrust, fatalism, especially in our community of East Harlem, there's a lot of attitude that if God meant for me to get colon cancer, there's nothing I can do about it. There's other issues, language barriers, etc. So we therefore implemented a patient navigation program. At that time, in the early 2000s, patient navigation had really only been a concept that was applied for women who had abnormal mammograms, navigating them to get a biopsy. It had not yet been really used for getting people into screening directly. So again, open access endoscopies where the primary care doctor just refers the patient directly in without a prior consultation. We felt that this would be more convenient for patients. There's a potential downside to open access endoscopy, and that is there may be potentially less understanding by the patient of the procedure, the indications, the prep, without that initial visit. But that's why we had the patient navigator. So a patient navigator is someone who guides the patient through the process of completing their colonoscopy after they've been referred by their primary care doctor. So the roles of the navigator are to assist with scheduling, any transportation needs, patient education regarding the colonoscopy, the rationale for the procedure, the importance of the procedure, the prep, to remind the patient about their appointment, and to help allay any fears that they might have. So we started this program actually in November of 2003. First, we had to set up the open access system in order to receive patients, and then our patient navigator was hired in April of 2004. Now, this study that I'll report on deals with we had only one patient navigator, a woman by the name of Annabella Castillo, who is a young Hispanic woman. Being in her early 30s, she herself had never had a colonoscopy, but she was a health educator. We educated her about colon cancer. Of course, she was bilingual, which helped us with our Hispanic population. We also wanted to make sure that insurance was not a barrier in this study. So everybody had a referral by their primary care doctor at Mount Sinai. Everybody had insurance. It might have been Medicaid, but everybody had insurance. So the referral by the doctor was not a barrier. The insurance was not a barrier. So the way this worked was the direct referral form was faxed over by the primary care doctors to the gastroenterologists, and either myself or Jennifer Christie, another gastroenterologist, would review the indications, make sure that there was sort of low comorbidities, and then we would if we approved it medically, we would hand it to the navigator. And then the navigator had 4 steps that she followed. She would make a scheduling phone call, she would send a reminder postcard, then she would do a 2-week phone call, and 2 weeks before the procedure, and 3 days before the procedure, another phone call. So with step 1, again, the patient was told about the reason for the referral, the importance of the colonoscopy. They would go over the medications to see if they were on aspirin or blood thinners. They would mail the prep materials, make sure they had an escort, all the concerns and questions. And then they were mailed a postcard, and on the postcard were the faces of the gastroenterologist who might be doing their procedure. We had 9 at the time. We had 9 gastroenterologists, men and women. We had an African American, a Cuban, Asian. Of course, on a given day, the patient may not know exactly which doctor would be doing their procedure, but they would get the sense that there were doctors with different. Everybody is a board-certified gastroenterologist, yes. And then steps 3 and 4, there were repeat phone calls to confirm that they received the prep, that they knew the appointment, they had the escort, et cetera, et cetera. So here are the results. So there were a total of about 1,169 referrals into the system, but only about 688 were eligible for navigation. 77% were successfully navigated. There were issues with sort of getting through to patients. We had the wrong phone numbers a lot of the time. In some cases, it was felt that a GI appointment was in fact necessary. But suffice it to say that 70% were navigated. Of the people who were navigated, the 532, 353, or 67%, 2/3 of people who were navigated actually completed their colonoscopy. But a disappointing 1/3, 33%, did not complete their colonoscopy. Despite the recommendation by their doctor, despite having insurance, and despite the navigator holding their hand all along the way, 1/3 still did not complete. If you look at the demographics of our patient, they're identical to the East Harlem population, about 55% Hispanic, 31% African American, and 14% other. And what we found in our results was that women, more likely than men, would complete their colonoscopy, and Hispanics were more likely to complete than other ethnicities. Family history, or on occasion, some patients might have had some minor symptoms. That did not sort out, but the vast majority of these procedures were screening colonoscopies. And on multivariable analysis, women were more likely than men to complete, and there's the odds ratio. Hispanics more likely than African Americans, and Hispanic women were more likely to complete than Hispanic men. We found about 16% of patients had adenomas. We found 2 stage 1 cancers, a high-grade dysplasia and a villus adenoma. Now, when we looked at patient satisfaction amongst those who completed, 64% of the patients said that they would not have completed their colonoscopy had it not been for the help of the navigator. Interestingly enough, about 84% of patients felt that the primary care doctor had actually explained the procedure reasonably well to them. But that went up to 92% when the patient navigator also helped explain. 35% understood the bowel prep by the primary care provider. 59% understood it after the patient navigator. So all these measures seem to go up, even though they weren't too bad already by what the primary care provider had provided them. So we were left with this victory in the sense that we got a lot of people in for colonoscopies, and we were all very happy about that, but the real disappointing fact was that about 1/3 of patients still did not complete. So are there behavioral or cultural issues related to this? Is there a possible role for peer navigation? So in this study, we had a young Hispanic woman, and we found that being Hispanic female correlated with more likelihood to complete. So could it be that if you had male navigators, could it be that if you had people who were over 50 navigating, doing the navigating, so-called peer navigators? So should this be culturally targeted? So we are now, Lena Jandorf, who's in the audience and it has been an integral part of this, we now have NCI funding where we are comparing peer navigators to professional health educators. We're also trying to disseminate the model of patient navigation to other hospitals and medical centers in New York City. So just the last two slides is really, we've done some focus groups at Mount Sinai to try to understand, particularly amongst the African Americans who they had the lowest rate of completion, what it is about colonoscopy that makes them reluctant to undergo colonoscopy. We had two focus groups of women, an N of 11, and one focus group with men. And you can see here, these are relatively low socioeconomic status individuals, representative of where we work in East Harlem, low income, reasonably low educational level. Most people were not married, that's come up before, but most people had Medicaid or Medicare. And what we were hearing was that I have no family history of colon cancer, so it's not relevant to me. I don't hear about colonoscopies that often. The doctor doesn't make my colonoscopy mandatory. I'm afraid of the prep, it's too difficult, the procedure is too invasive. Men felt that if the prostate exam was normal, then I don't need colon cancer screening. They thought that a digital rectal exam was a colon cancer screening exam as well. My friends haven't had colonoscopy, why should I? And in women, interestingly, some women felt that they wanted someone else in the room during colonoscopy because they weren't sure what was happening when they were put asleep and who was in the room. So a lot of issues come up when you do focus groups, and maybe some of this relates to local sort of patient populations and local issues or perhaps even cultural issues, and we're going to try to tackle that. I don't have time to list everybody who was part of the program, but I want to thank everybody who helped us participate in this. I also want to mention that all of the doctors that did the colonoscopies, many of them really gave their time to do this. There was a sort of volunteerism type of effort because many of the Medicaid colonoscopies, for example, don't pay that well. So you do have to get buy-in by your staff as well. So thank you for your attention.